Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Today, I'm sitting down with Leanne Shared, who's joining me on the podcast today. You guys are so lucky you get a treat. It's Leanne and Leanne. So Leanne's going to be talking about telepractice, the fundamentals and advantages. Leanne founded a teletherapy private practice. So she's coming on to talk a little bit about that, about starting that company, the idea behind it, how it's working out, and she's sharing with us the things that they've learned along the way, like navigating telepractice guidelines, talking about state licensure, HIPAA compliance, insurance considerations, documentation considerations, thinking about the appropriate populations for telepractice, and then, of course, the good parts, like the benefits, why telepractice could be a great solution in targeting functional goals, working alongside caregivers. It's just a little snippet of what Leanne's going to go over with us today. So yeah, I'm really excited. This was a really fun chat, and I'm super happy to share it with you guys. My name is Leanne Porter. I'm the host of the Speech Uncensored podcast, and now let's hear a little bit more from Leanne and Leanne. Leanne and Leanne. Leanne and Leanne. Leanne and Leanne.
Welcome to the Speech Link. I'm your host, Sharp O'Shart, and I invite you to listen and learn practical strategies from experienced experts to take your therapy to the next level. It has to be a scary feeling, especially for a 7-year-old, to not be able to catch their breath, even for a few seconds. This is what happens when someone, and it could be children or adults, has vocal cord dysfunction. Now, VCD sounds like a very general term, but it has some really specific symptoms, and we, speech-language pathologists, need to be aware of them and what to do to help these individuals in distress. We have an expert in the house on this topic. Grab your pen and paper and get ready for a fascinating discussion. Here we go. Jayanti Ray, PhD, CCC-SLP, is one of the most knowledgeable and educated ladies I know. She earned her degrees, including her PhD, in India in the late 1990s, then came to the United States where she joined the faculty as an assistant professor at Washington State University and was there for 5 years. She then moved to Southeast Missouri State University, where she's a full professor and currently teaches undergraduate and graduate courses in the Department of Communication Disorders. Now, notably at SMSU, she was awarded the Outstanding Teacher Award in 2019 and the Outstanding Researcher Award in 2013, 2015, and 2017. She says that her teaching and her research interests are varied, and I would agree with that. She's interested in voice disorders, which is what she's talking about with us today, oral myofunctional disorders, cognitive impairments, and neurogenic speech disorders. She's presented numerous papers at the local, state, national, and international conferences on a variety of topics. Very importantly, prior to joining academia, she worked as a speech-language pathologist and consultant in pediatric as well as adult home health, skilled nursing facilities, hospitals, and private practice. She's done therapy. And I think that is so very important for university professors. So welcome to the Speech Link, Jayanti.
Thank you so much, Shar, for having me today. I am very much honored and looking forward to the entire speaking event. Thank you again.
Thank you. Now, you are talking with us about a really interesting topic that I haven't heard too much about, but wow, it seems important. Vocal cord dysfunction. Seems like that could go any different direction, but what exactly is that?
Well, when we hear about vocal cord dysfunction, we tend to think about our vocal folds. Now, what is wrong with the vocal folds?
Yes.
Well, vocal folds to us mean that we are always thinking about our voice, but it is not about so much voice, but it is a respiratory condition characterized by paradoxical closure of the vocal folds during inspiration. So it means when we are breathing, we keep our vocal folds in an abducted position
Mhm.
where air can pass through easily without any resistance or with least resistance. But that way we get our oxygen we need. But in VCD or vocal cord dysfunction, it is very different. The vocal folds try to close when you're trying to breathe in, and that means there's a little struggle getting the air into the passage, and as a result, children might show, or even adults, they might show some kind of noisy breathing, or that's called stridor, or sometimes they would have so much of discomfort that they might think that they're suffocated, or they're having some kind of strange feeling, some tightness in their throat, some tightness in the chest, and so on.
Oh my gosh. That's scary.
That is scary.
Yeah,
Yes.
that is very scary. Now, you said paradoxical vocal folds, something or
Hmm.
other. I suppose I should know what that is, but I don't. What does that mean?
Oh, paradoxical closure of the vocal fold means, as I explained, like when you need to breathe in, your vocal folds, the two folds, should be far apart, like in an abducted position
Right.
to let the air flow through. But when you are actually using the vocal folds for voice, they're supposed to kind of come close to the center and start the motion, and they get into vibration, and we are able to produce our voice. But when for breathing purposes, the vocal folds are supposed to stay out from the midline, and that's why it is called paradoxical closure, because instead of keeping themselves open, they just close down at the time of breathing.
So it's just basically doing the opposite. So it's a paradox.
Are doing the opposite.
Okay.
There you go. There you go.
It's a paradox. Okay. All right. Well, that's a fancy name. Why don't they just say that? No.
Yeah, I know.
All right. So it's basically during breathing then, when you're trying to breathe
Yes.
in. Oh my gosh. Okay. Tell me some more of the signs and symptoms so that if I see somebody that has it, then I can kind of recognize that. So obviously, they're going to be in distress. Are they wheezing or are they trying? What happens? And as you're talking about this, are there different levels or does it just close or are they closed partially? Is there like a variation of closures?
Yeah, absolutely. I can talk about that. So, there are a variety of signs and symptoms that we see due to this condition. So, first thing to note is that, yes, as you mentioned, there is a stridor, like noisy breathing. So, typically, yeah, children or adults, whoever gets into this episode, they find it very difficult to get out of it. They feel like they are suffocating, they can't get enough air to breathe in, and they always feel that struggling to keep the airway open, but nothing they can do about it except just wait it out. So now the other things that happens over here is that the vocal folds are not closing all the way, but there is a partial opening in the vocal folds. It's like a slight chink you see in the posterior part of our vocal folds. The space between the vocal folds is known as the glottis, and if you go to the posterior part, you see a tiny little space through which air passes through. But imagine you need the entire vocal folds to stretch out, and you're only using that partially created window to breathe in. And that itself speaks of all this trouble and struggle that goes on with this VCD. And due to this, there's some periods of breathlessness, and that's a time like students in classes and students playing out in the field, and if they're planning on getting some physical activities, they find it very difficult to continue with their activities because there are some breathlessness periods where they really cannot keep up with the oxygen demands. And because of this continuous struggle, they end up showing some symptoms of anxiety, and sometimes they're really uncomfortable and really don't know what's happening. So, again, it's kind of those signs and symptoms one has to be cognizant of. But sometimes they also show coughing, and this is kind of coughing to keep the vocal folds open. So when they feel like they can breathe in, they have to do something to the vocal folds. So they, in order to make sure that the vocal folds kind of open at least after this cough. So they try to cough all the time. So it becomes like cough behavior which persists for a long, long time, even though there's nothing coming out of their airway, but they're still coughing. And because it's just to make sure that their vocal folds are moving somehow. Because what happens in cough is that we adduct our vocal folds very quickly. It's a tight closure. Then all of a sudden the vocal folds open because that's what happens in cough. So pretty much, if you see younger children having this VCD, we tend to find out that they cough. As it's kind of a nice little strategy to keep their vocal folds open.
Yeah.
And of course, along with the cough, you could also hear some stridor, that's the noisy breathing. And the episode, yeah, it lasts for about a few minutes.
Wow.
And I've seen children where the episodes last about a few seconds and they are just fine after that. They come, get back up on their feet and they continue with their activities. But sometimes it becomes a real struggle. And in case someone doesn't know, like, what's going on with them, they probably would look at the symptoms and say, oh no, call 911. And the child has to go for seeing a doctor at the emergency. So,
Wow. So you're saying that it can happen a few seconds to several minutes.
yes.
Are there spasms in the throat? I mean, what's going on to make these vocal folds close?
Yeah, that is something it draws back from our nervous system control. Sometimes, okay, if we have to just take a deep breath, we do that. It's kind of consciously done. But sometimes when you're just breathing for life, we are breathing just when you're engaged in some activity, we hardly think what is happening at the level of the larynx. Are we breathing really? So our attention is not on that. Our attention is drawn away. But what happens with this VCD, like one of the theories says that there's some problem with the timing aspect of the vocal folds.
Mm-hmm.
So the vocal folds get into some spasm because a higher order neurological center is not sending appropriate signals down to the vocal folds to maintain that timing. Inspiration timing and expiration timing. See, the problem is that in VCD, there's nothing wrong with the expiration phase, because when you look at expiration, they're just normal. They can breathe out easily with no restriction whatsoever. But the moment they want to breathe in, that's where the struggle begins. And that's because of the faulty nervous system input, also faulty timing of the vocal fold muscles, because the muscles are supposed to do their work for inspiration. And the muscles we use for inspiration are the posterior cricoarytenoid muscle. That's the only muscle, I would say that's a breathing muscle, because that is in the larynx. It's only used for abducting the vocal folds for breathing purposes.
Ah, that's the culprit.
Yeah.
I remember working with a child whose upper chest area was very tight all the time. And his voice was tight. I'm wondering if maybe, if there was maybe a little bit of this. I mean, during the episodes, you're obviously going to see a child that's in distress and having difficulty breathing and so on. Is there a precursor? I mean, or is there a low grade tension that goes on prior? Is there anything that surrounds it before and after as far as symptoms that we could pick up on?
Oh, yeah, that is a great question, actually. Sometimes it just happens and the child doesn't even know that it's going to happen. But sometimes you feel like just before some very highly stressful activities, for example, the child has to go to a competition or the child has to do a race. And all of a sudden, if there's too much anxiety in the system, it triggers your autonomic nervous system in such a way that it gets some wrong signals to your vocal folds. And sometimes you never notice that things are happening. But yes, you brought up the chest tightness. Now, chest tightness, I would say that is mostly with asthma. Children with asthma would say, oh yeah, my chest feels really tight, it's heavy, can't breathe out very well. But the children who show BCD episodes, they actually would touch their throat area and say, "Oh, I'm having tightness here." Now that happens without their awareness. They're not aware of that, but they just happen to take their hands and put it on their neck and probably anterior, throat area, and they say just hurting in the front, like just, and they will just
Mm.
hold their neck and hold their throat and say it's kind of tight everywhere. So that's a tightness. It comes from those muscle spasms, of course, and and that episode, how long ever it lasts, it just continues to build up on those symptoms. And finally, when it relaxes, the child thinks, yes, the child is able to breathe again, and they
Mm.
realize that it had been a horrible episode where they
Yes.
were not able to breathe well, and that even heightens their anxiety.
Oh, yes. I mean, I'd be scared to do a race, or I'd be scared to get into my competition, whether it's, music or whatever.
Mhm.
Wow. So before we continue on with the causes, now you have seen people and kids and so on that have VCD. You've seen the episodes. Okay.
Mhm.
Can you describe maybe one or two of these kids and what you have seen and what they have gone through?
Okay, that I could just start with a 6-year-old little girl who came to our clinic because, okay, sorry, I think she was 7 years old when she came to our clinic. And for the past 1 year, the mom described that she was having intense problem breathing, especially when she would go to the field to play some games with her classmates. And she had this great anxiety, and the mom never knew where this came from because she felt that everyone else in the family was pretty relaxed and laid back, but then she was having some sort of anxiety based symptoms during her tasks, and no one realized that that could be a possible cause of her breathlessness. But anyway, there were 2 or 3 episodes the mom noticed, and after a year, I think she came to her clinic, and those episodes had increased. And she came to know that she could just go to any university clinic and see a speech pathologist. And I don't think they got any help at the school because they thought that it was something that came and went and nothing
Mhm.
persisted. So she did not receive any services from the school
Mm.
speech pathologist. So she came to us,
Mhm.
and the mom, yeah, she expressed that her daughter was having problem with breathing, and she would cough so hard that everyone in the soccer field or any other playground area would just make them look at her, and it used to draw lots of attention from other people because she would cough and cough and cough and will not stop
Yeah.
until the time she felt that she was able to breathe. Now, isn't that like something that tells us, like, why would she start coughing and then stop? And when she would cough, it used to be really, really loud cough. That's what her mom explained.
Uh-huh.
Now, when she came to her clinic, we actually did some testing on her, just tried to do some test of breathing to see, like, if she showed some sort of breathlessness anytime. We made her read, and she was a very good reader, I remember. So she was able to read for us, and we're thinking like, oh my gosh, could he see some episode happening? We actually tried to scope her. We did video endoscopy. We took the scope through her mouth. We couldn't do the nasal scope because there were some restrictions in using the scope because we had an adult scope and not a pediatric scope.
Right.
So with that rigid scope, we saw her larynx was just normal. She had a beautiful vocal folds, all hydrated, and she looked like she was good taking care of things, and there were no allergies, and everything seemed to be fine in terms of coloration. There were no infection. The mucosa looked good. Then what is wrong? So we couldn't see anything. Now, when the symptoms of BCD happen, we really cannot capture that. Sometimes we are not there when the symptoms
Mm-hmm.
happen, and then when the person is going through that episode, we have to stick our endoscope to see like what's going on with the vocal folds, but that is not possible.
No.
So we just thought, well, based on the symptoms, and now that's the tricky thing, that we want to rule out everything in order to rule in VCD. So we thought,
Right.
do you have asthma? Do you have any medications that you take? And they go, no, no, no. Okay, so this happened. So we were thinking that this is by isolation. That could be only VCD. Now, I would like to explain a little bit more about that. She did complain some tightness of her chest, which is typically a symptom of asthma.
Mhm.
But she didn't mention anything about her throat. I thought, okay, that doesn't match very well. But yeah, she had some audible stridor. Like mom explained that she would breathe sometimes very heavily and will make sound because she's just trying to cope with her breathlessness sometimes. Suppose she's running and she has to catch up her breath. So we actually tried to simulate the situation. We told her, okay, let's run. Let's just get into the treadmill and I will see like if you get the symptoms.
Ah,
So she did. After about 7 minutes of running, she could not maintain her breath support. I thought,
really?
okay, was the episode indeed coming? And it didn't come. She overcame the thing, and it just happened that she was, just back to her normal self and said, well, I'm just very much relaxing and let me know what I need to do next. So those were her words.
Hmm.
So we said, well, all right, let's do some more. We gave her more tasks.
Right?
And she did not have any episode during that evaluation, but she went through therapy. We had just, I'll get to that later on. So some of the therapeutic aspects really, really work very well with children having VCD or VCD-like symptoms, and they get benefited from that.
Yes. Interesting. So you couldn't initiate an episode, is what you're saying.
No,
Isn't
we
that, yeah,
tried.
poor kid. Oh my gosh. And she was 7.
Yes.
And she knew probably what was going on. I mean, what was her description of it? Did you ask her, tell me what happens?
Yes,
What did she say?
absolutely. When he told her what happened, she just mentioned, I think I have trouble breathing. That's what she said. And she
Okay.
pointed to her upper chest, like especially where you have the breastbone or the sternum, that area
Yes.
right below our neck. So she just pointed there and said, oh, I think I have some tightness over there and it feels funny. And I don't know what
Hmm.
it is, but she mentioned that she didn't touch her throat, or especially children with those episodes, they usually point to their throat, but that was something off. But then she
Huh.
presented with some hoarse voice. Probably she was coughing a lot, and when you cough a lot, your laryngeal mucosa go through some strain and stress,
Mhm.
and as a result you might develop some mild hoarse voice. And that's something we find in the literature as well, that children with VCD, if they're having some coping mechanism, especially coughing, then they might end up having some sort of raspy voice. So she did have some of it, but not quite obvious. But we did the testing. We did some acoustic voice evaluation with based on the numbers. We found that yeah, she was slightly off, but not so bad that perceptually we had to tell her, oh no, your voice is really not that good. But anyway, she also told us that she had trouble sleeping because she'd be having some anxiety, in the sense she couldn't go back to sleep after waking up, and which we felt that that's not probably within our territory. We thought it would be something the physician could consult with her. So she did explain about that. And then she also mentioned one thing. She felt that when she ate food, she felt something funny going on in her throat. And I thought, well, is that something called reflux? She didn't know the term, but her mom said that she had some digestion problems. And we
Oh.
thought, oh, probably there is some link over there, like why she was getting those episodes. And as if a child has acid reflux that has not been treated for some time, their laryngeal mucosa, they get those refluxet, like the things that come out of the stomach, they touch the vocal folds. And sometimes that happens at night without the knowledge of the child or the parents.
Mhm.
And the next morning they wake up, having a weird taste in their mouth, and they might feel like a little bit, in a sense, like restless, because it's not just the greatest feeling when you wake up. And probably they could have lost some sleep at night, so they end up waking up having some sort of fatigue.
Mhm.
So she mentioned all of these symptoms, and she didn't say that I am anxious or something. A child can say it, but she said, I'm just worried about
Sure.
getting a rank. I'm worried about this race. I don't know if I can do it, but I feel like I can breathe very well.
Okay.
So that's what she mentioned as a symptoms.
How long had this been going on? I mean, how early does this start?
Yes, she actually got this. Our mom noticed all these symptoms when she was 6, so it took them a year to figure out like what they should do. So she would cough, and they felt that, oh, probably it is allergies, and they took her to her physician, her pediatrician, who said that, well, they ruled out asthma, that she didn't have any asthma. So she didn't get any care after that, but her symptoms continued for a year. And then the mom found out that she could bring her to our university clinic. And I was the person many years ago to see her. And my entire class with my voice students, they were so excited. Each one of them did something for her, like a little activity, for therapy. And we just had a ball, like I would say, just having her in class for a little time and giving her the treatment. But if at all I can mention this here, like she totally outgrew that problem. And when he followed up, her mom said she never ever coughed anytime at the soccer field, or probably she just got her anxiety level down. And with all the therapy exercises, she was made more aware of herself. And since then, we knew that she was doing fine, and we didn't have to do any follow up, because the condition was that she would come for follow up if at any time the mom or she felt that they have some symptoms or they noted something very different.
This causal piece, I mean, I'm hearing that perhaps stress in a person's life,
Yeah.
emotional stress, and then I'm also hearing physical stress, like out on the field and running and so on. Maybe even something in the atmosphere, smoke or something. I mean, I don't know. So is there definitely a trigger that happens, or does it just happen due to a neurological glitch? I mean, or is it a combination of both, or do we know?
Yeah, theoretically, yes. There's some neurological things going on. Otherwise, why would a person have this spasm? So the spasm part is explained at the neurological level, but there are some triggers, definitely. So we have theories, we have causes, we have triggers. Now, we do not have enough evidence to suggest that one of the causes should have strong correlation with the symptom or a sign or anything. But it's good to explore everything to see what might be the cause and what are the triggers. And knowing those causes and triggers, I think we get better with the line of treatment. So as you ask, like what are other causes, I would say something like allergic rhinitis or some um, inflammation going on in the oral or nasal or pharyngeal mucosa. There could be something like if the child is on some medications, it could be a reaction coming from that medication. So literature supports that type. So your respiration rhythm could possibly change without your knowledge. So this is kind of scary things. And then they also suggest, as I mentioned earlier, like having some sort of neurological underpinning. So we're not sure about that, but just at the theoretical level, we have some explanation there. But some other causes would be laryngeal reflux, like we call it actually laryngopharyngeal reflux, called LPR. So you may not get any heartburn, but in case you have food and if you have some reflux conditions, it just makes you feel uncomfortable, because mostly at night the food particles or whatever is in our esophagus comes up to the pharynx, and then from there it quickly goes to the larynx, touches the vocal folds, and then they go back down. And no one ever knows how that happens and if there are any symptoms. It just is a silent reflux. That's what I call it.
Interesting.
And then we have another cause like GERD, in case a child has some gastrointestinal problems and they have gastroesophageal reflux disease, which is GERD, then it's quite possible that the GERD triggers something in the diaphragm, and the diaphragm triggers something and maybe there's some communication to the muscles in our larynx, and probably that just disrupts the rhythm of respiration.
Wow.
So there are some theories that actually relate to those causes. But when you look at triggers, oh yes, there's some literature that says triggers could be anything in the environment, like pollen, other pollutants, and something in the air, like if there's some abnormal composition. And sometimes we see air which is kind of slightly depleted of oxygen. You just can get those triggers. So it could be just anything in the air that you're not used to. It could be just a simple perfume, or maybe
Ah,
smell of food. So those could be triggers as well.
interesting. Because I know sometimes certain perfumes or different odors in my own life,
Yes.
I get like a little allergic reaction or something. I don't know. I think things start swelling and nasally, and that there's an
Hmm.
allergic reaction. So maybe what you're saying is that many of these triggers are triggering that person's response. Like when I smell something that doesn't agree with me, then my system reacts in a certain way.
Hmm.
So their system is reacting in a certain way. There is a propensity to have that laryngeal response.
Hmm.
Am I making sense here?
Yeah, absolutely. You are just doing great. Yes.
Okay.
So it is pretty much individualized. Like, maybe my system may not be triggered by a scent that could possibly trigger someone else's system. And what it does, it's an allergic reaction that leads to some sort of breathing problems. And finally, there could be some shortness of breath and breathlessness. You can call it anyway, like dyspnea, shortness of breath, or breathlessness. But one another important thing that I forgot to mention, it could be exercise induced as well. So the BCD symptoms may not be there, but suddenly you start swimming, or suddenly you think, okay, let me just take a walk or brisk walk or just me run. So you get to see those symptoms appearing. So it's kind of tricky, like when it happens and when it doesn't happen. But when it happens, you have to know like how to cope with that.
Do these people get dizzy? I mean, is there actual oxygen deprivation?
Yes, there is some oxygen deprivation. So that one could be confirmed by a pulmonologist who actually does testing for inspiration and expiration. It says that during their inspiration, because their vocal folds are not fully open, so they can't get the right amount of air inside. So their oxygen input is lower than during other times when they don't have the episode. And the expiration shows perfect.
Yeah.
It's perfectly all right. So it's just the inspiration part which is like a little bit low, and it shows there are some graphs and loops that are used to just see those test results, and they can explain that their inspiratory loop is kind of I would say smaller in terms of surface area. So if you have a larger loop, that means you have more space for oxygen. And then when the loop is smaller, that indicates your inspiration is not adequate or up to par.
Well, let's stay on causes for just a few more minutes here.
Yeah, sure.
Okay, there are some kids that are very athletic.
Hmm.
So are we saying that every time they go out and run a relay or whatever, that this is going to happen? Or is it just cyclic? Or maybe this happens with most kids, once a week, or maybe once every other week. I mean, what's the frequency, or can you predict? Or are these triggers pretty consistent? Do you get these breathing responses every time this trigger happens? Or is it just sporadic?
I think I will pick up on the word sporadic. So we really cannot predict anything. Sometimes kids, there are so many kids I see, they're working hard, playing games, and they're really pushing hard to get to the level where they want to play at. But I don't think all the kids go through that. But some studies on little children from their age range, let me see, 7 or 8 to all the way to 14. There number of studies, I would say, that have been performed for that particular age group, they felt that only 14% to 16% of children were actually demonstrating some signs of VCD, and other children who had some signs, some discomfort, they ended up having some diagnosis of asthma. So it's interesting to note that we do have great athletes, but they have asthma,
Right?
and sometimes you do have VCD in isolation, like there's nothing else but only VCD. And sometimes we see coexistence of VCD with asthma, and those are really tricky
Whoa,
children.
that's awful. Oh my gosh.
Yeah. So exercise induced VCD, it's easier to diagnose though because you can hear the stridor, the noisy breathing very clearly. It's difficulty with the inspiratory phase only, and then they have throat tightening or sometimes chest tightening, and sometimes they would say that they are feeling a little bit uncomfortable during the whole thing. And if they know, then they will just wait it out. It's no problem. They'll just lie down and they'll make sure that they have enough oxygen to breathe, because they can't merely have that standing posture. So they are actually, in a sense, it is better for them to just rest or lie down, and so that they can just get the oxygen they need.
Yeah.
And sometimes the onset is very abrupt, like you never know it's going to come to you.
Oh.
And there is a nice and quick resolution. So there should be no problem with that.
Does lying down, does that impact the vocal folds at all, or does it just make them relax, or maybe lessen the possibility of them falling over because they're dizzy, or all of the above?
Yeah, I think the lying down posture just makes them aware that they are going through these symptoms. And if they are dizzy somehow, you're actually predicting that if they fall, that could be more dangerous. And if they're just lying down and having some rest and recovery position, they should be up on their feet in no time.
All right. So going back to that other question, so it is sporadic.
Yeah.
And it's not like the trigger triggers a response, a VCD response every time. It's just sporadic. You don't know.
Yes.
Okay. That's kind of scary in itself, actually.
Yeah, it is. Because sometimes, we try to simulate that. I said, well, if smell triggers some BCD, there was an adult client. I want to talk about in this presentation about adult client, but I'm just saying, if you would like to see like what is a scenario like, we tested that client in a clinic and we just gave him several different things to just smell, including bleach. Gosh, and he said that every time he used to clean his bathroom or something, he'd get into an episode, and that's why he stopped cleaning his bathroom. We gave him all these chemicals, and he had no problem. I said, okay,
Interesting.
that is difficult
Yeah.
to just kind of see like what the literature says and what he complained of, and we couldn't elicit that. So that means it is, yes, I would say anecdotally and also based on the literature support, we could say that yes, these symptoms are pretty much sporadic.
Okay, so let's go to the incidence and prevalence here. You mentioned something about 14 to 16% of, what were they?
Yeah, probably 7 to 14 years of age. And this study that was done on more than a couple of hundred children. I don't have the study here, but though that study particularly tried to look into the symptoms of VCD and come up with a prevalence and incidence figure, but that's not available, like the exact VCD incidence and prevalence, because it's so tricky. There's so many in a sense, factors and variables to look into. So the studies are pretty much limited. Now, reiterating that study, I would say VCD was only a small percentage, but more than VCD, the children had asthma, and then a small percentage had VCD and asthma together.
Mm-hmm.
So that actually asthma is kind of predictable. It is, you can actually see someone struggling with asthma signs and symptoms. They get their medications. If they continue to have the medications on time, they pretty much can get better.
Mm-hmm.
But with VCD, there are no medications as such, so you have to kind of use other techniques and use some knowledge to make sure that you are out of that episode quickly.
So I'm hearing maybe, teenagers have this. Do
Mhm.
adults as well, or does it manifest in fewer adults?
Well, for adults, the BCD manifestation is little different because there's more neurological conditions that come into play. And I'm not saying that there's no psychological issues like anxiety, depression, or stress from life. Yes, those are symptoms. And I have treated more than, I would say, 15 to 20. I can't remember.
Oh,
So those are all adults
really?
and had BCD. I can't imagine. All of a sudden, probably there was awareness all over. I guess people
Oh.
recognize the symptoms. And from time to time, I saw all of these adults with BCD. Some of them had some problems, like they would have blepharospasm, where their eyelids could
What?
close on them.
Oh,
There were some spasms, and because of they had blepharospasms, like eyelid spasms, they had laryngeal spasms, and their complaint was that they would just address something at a table for 12 people and they're trying to project their voice. All of a sudden, they have breathlessness and
Wow.
they can't continue. So that's another thing I learned. Like, when you learn a lot in the clinical field, I guess I don't get to learn as much by just reading. It is always true that we interact with our clients. So they just opened my eyes to it and
Oh,
what was
yes.
going on.
Sure.
And some of them had stroke. So we don't know if there's some neurological
Yeah.
underpinning there as well. And they were otherwise, great communicators, but they were not able to get out of the VCD conditions because every time something new would come up. And there's one website, I think it's called Can't Breathe suspectvcd.com, that has listed probably over 100 triggers. So since you were mentioning about triggers, and sometimes you never know if you ruled out like probably 20 or 30 triggers and there's one other one you didn't talk about, and that person gets exposed to that and gets into that episode.
What was that website again? Can't breathe what?
Can't breathe suspectvcd.com. Actually, that website came from National Barnes Jewish Hospital.
Oh,
Well, there was a nurse who had BCD symptoms, and I did not visit the website recently, but it has a wealth of information on BCD. It's called Can't Breathe suspectvcd.com.
somehow I just thought that you grow out of this, but
Yes.
not really, huh? I mean, a lot of people don't. So the adults that you worked with, had they had this for long term, or maybe they had it as a child and then it left and it came back, or maybe it just started as an adult?
Actually, they couldn't. That's a very interesting question. They couldn't tell us like whether they had episodes like this when they were younger. So I think when they were adult, they noticed the problems they're having. They were having problems with breathing, and 50% of them, if I have a good estimate, they all said that one point or the other they were in ER waiting for their physician to evaluate them and say they're okay to go home without any other treatment.
Yeah, the episode stopped.
Yeah.
Yeah. Wow. Okay. So
Hmm.
move me into therapy. And, I imagine that speech language pathologists are involved in this and maybe we help them to relax or something. But what do we do?
Well, when we say treatment, the first and foremost thing is to see like what is causing the problem.
Yes.
Well, the answer is very difficult because there's so many causes. We really don't have enough evidence to say, well, this cause probably correlates with this symptom and so on. But if we find a cause, it's great. But sometimes it's very difficult to evaluate that. So we just try to see like what are some of the environmental substances or environmental pollutants or allergens that the child has hypersensitivity to. So if those are the triggers, of course, yes, they are under the category of triggers. We just try to find out could we possibly reduce those triggers. If the child cannot tolerate humidity, maybe you should reduce that. If the air is too dry, maybe you could do something about that. If the child has allergies, could he possibly ask the physician or the pediatrician to provide the medications? Yes. If the child has reflux, are we doing anything about that? Did we take care of the child? Did we talk to the parents? Did we talk about do's and don'ts? So those are the things to kind of consider, and thereafter get down to the larynx because that's the major point where all these problems are actually sourcing from.
Yes.
So we look at the tension in the laryngeal area, like how do you do that? We have to kind of see to it that they're not overtly showing some sort of tightness. But when you, if I say, take a deep breath and kind of say, ah, it's good. If I take a deep breath and say,
That's
ah,
not good.
so that's not good
Yeah.
because there is some tension. Yeah. So we need to make sure the child is not putting undue tension in the laryngeal area. It should be relaxed. And so we try to take them through the journey of tightness in the muscles and relaxed muscles. So we educate them. That's the main part. So we try to know more about them, their environment, their habits, food, and everything. And then we try to see, like, what exactly is the tension? Is it in the laryngeal area? And then we ask them, so how you're breathing? So if anything has to be done to just change their respiration pattern, are they like kind of using altered breath? our breathing mechanism. For example, if they're using a lot of shoulder movement, a lot of neck tightness, or if they're using their upper chest alone to breathe, I would say, yeah, that's kind of not really conducive to a solid posture for breathing or some prolonged, I would say, intake of oxygen. So really, they cannot do all those if the breathing pattern is not normal. So all of us know that already, that we need to establish some sort of stable breathing pattern so that there's enough oxygen in the system, and also when the oxygen goes out of the system, we are in full command of that airflow. So especially when speech pathologists are working on speech sounds or they are working on voice, they have to make sure the exhalation part is not ignored. So we do want the inhalation part to be taken care of, but sometimes, we have to also understand that we're using the same muscles for inhalation and exhalation at some point, because it's not always isolated action. So we are using our inspiration, for inspiration we're using our muscles like external intercostal muscles. So yes, those muscles are for inspiration only, but they are also used during expiration because you are having some sort of checking action on them. So we should not, or means in a sense, we do not want to hyperventilate, or we don't want to use too much force on the muscles. We want to just have optimum flow of air and optimum flow of air out. So taking a look at all the muscles and taking a look at the diaphragm, all speech pathologists kind of understand it's so important to establish some diaphragmatic breathing. So yes, for treating BCD, we do use the term abdominal breathing because that's more conducive to what happens. Instead of just focusing on the diaphragm, I think we focus on many muscles that actually give us a good posture to breathe. So that's why we call it abdominal breathing.
Mm-hmm.
And if we are able to stabilize that abdominal breathing pattern, that means to say we are strengthening the entire system to deal with those BCD like episodes, if at all they are there. So what do we do? What do we teach our clients? Or how do you work?
Right.
Now, for respiration, we could actually have lots of different activities. Like a simple activity I've done for those kids is like giving them a cup of water and a straw.
Mm-hmm.
I love
Mm-hmm.
straws, okay? I give them a straw and a cup of water and say, hey, could you please take a deep breath and continue to blow through the straw into the water and see how long you can sustain that breath. Now that is relaxing the system a whole lot. So they take the cup of water with water, and I make sure it is not overfilled or something. It's just up to 50% mark. If it is filled, then the kids can just blow water through the straw and maintain their breath support. And I tell them, you know what? If you could just maintain a steady flow of air, not too turbulent and not too low, so you just
Mm-hmm.
do the right one. And I always try to get another cup for myself and explain them. So that actually make them stabilize their abdomen in a very different way.
Huh.
So they continue with that for 15 seconds. Who gets 15 seconds of breath out? So and then also we talk about deep breath in, so inspiration. So that helps a lot. And we also do something to stabilize their abdominal breath support by using some speech, because all the time you cannot breathe like for 30 minutes or 50 minutes. We use some exercises for voice. For example, I might say, take a deep breath and say, ah, which all of us know that we do the phonation duration part and see if the child has the optimum number of seconds for phonation depending on their age. So for a 7-year-old, for a 10-year-old, I'll have different values that I would just ask them to attain. So sometimes I ask them to read some materials. If they are good at reading and they're okay with it, I'll say, okay, you are only going to pause at certain times, but don't, if you feel like you're struggling to take a deep breath or you feel like pausing, do so, but realize that we are going to go over that phrase completely and then take a breath. Or if there is a period, we take a short, quick, deep breath. So the reading materials that I used earlier were very helpful. And then sometimes if we really didn't feel like reading something, I would say, hey, you know what? We can do some counting. So let's do this. It's called words per breath. So we would do, let's say, 1, 2, 3, 4, 5, 6, 7, 8. Probably you realize that I did not take any breath in between. I went
Mm-hmm.
all the way until 8 and stopped. So uh, so that kind of helps them to stabilize their breath support a little bit more in a fun way. So we play with numbers, letters, names, and okay, well, if you have like two long words, then we cannot probably do it. We have to make sure that word length is all maintained. But that's something you could do. And then it is interesting, like we need to tell them beyond these breathing exercises what they could possibly do when they have an episode.
Right. That's what I was thinking too, is that, somehow we need to get this child through it, knowing that they have some level of control as they're in it, so that does take away some of the stress.
Yes, and that is a great question and indicator. I was going to get to that.
Oh,
Yes,
good.
it's the breathing recovery exercises, or you can call them rescue breathing. So, what is the rescue breathing?
Okay.
So, whenever they feel that they are having some tightness and they're about to get into that episode, so with proper education about the entire thing, I think I was so successful in just telling the 7-year-old girl, say, hey, if you ever find out that you're getting some breathlessness, please do this. Now, what I train them is what is there in the literature. Of course, we follow evidence-based practice. So something that really helps is to make sure we do relaxed throat breathing. That means to say we have to relax the back of the throat so that all of those tissues and all, they have enough space to hold that oxygen and the air. And to do so, we have to make some constriction in our mouth, like at the level of the lips. So that's what it makes the difference, is that we're able to relax our airway if we have some constriction at the level of the lips. So that's called the semi-occluded vocal tract. So that's what the name is, but that's a concept. But again, if you're just doing the breathing for rescue, we tell them, let's not worry about what is happening at the level of breathlessness. You'll be just fine. So what you need to do is just to take deep breaths as usual. You don't have to pant or get anxious about it. Naturally, normally take some deep breaths. And when you release the breath, you just take your tongue slightly out in between your teeth and just relax and say, like a sa sound. So when you're doing the sa sound and continually doing that, you're actually increasing the dimensions and the area in your pharyngeal level. So you're able to have some relaxed throat breathing. So the constriction is in the front of the mouth. So some studies say that it's good to do the F sound. So it would be like taking a deep breath and saying, or taking a deep breath and saying, and that's what we could do. And then sometimes when we treat these children, we ask them to be aware of their breath support. And to do so, we tell them sometimes to take deep breaths through their nose as well. So nasal breathing is supposed to relax the larynx. So it's that kind of connection. So we try to pursue nasal breathing patterns, and that's what in yoga also we learn, that sometimes we occlude one nostril and then take a deep breath through one of the nostrils and then release the other one and use the alternate nostril for continuing to breathe. So that helps really. So nasal breathing, but in case they're having their mouth open, then we could say, oh, keep your mouth open and let's breathe. And sometimes we could also ask them to breathe through their nose when their episode is kind of under control. They don't have to really panic. So it's a whole lot of education, I would say. And the breathing recovery exercises help a lot in managing their behaviors, like if they're too anxious or stressed out, that really calm those exercises really calm them down, and they are, means in a sense, they are cognizant of the fact that they should be okay in about a few minutes. It's just a matter of few minutes.
So doing the TH type of thing where the tongue moves forward, that one seems logical to me, to sort of move the tongue and the muscles out of the area of the pharynx. I mean,
yes, that's right. Yes, exactly.
Our time is very short here, but I want to ask you, when the jaw is open, are we helping or hindering the laryngeal area?
Yeah, that is a very good question. So, some theories suggest that the jaw is open. We are kind of inducing more anxiety because they try to pant a whole lot and try to think that they're going to get a whole lot of air through their mouth. But the main problem here is that if we constrict at one point, the vocal tract relaxes in the other end.
Mm-hmm.
So that semi-occlusion, that concept comes from the point that when we want to relax our laryngeal muscles, we have to have some tension in the lips and draw our attention away from the throat area and try to do something with the lips. So engaging the lips during that episode, it makes a big difference. So it's kind of a
Interesting.
little sensory trick. So I know that I'm not able to breathe. Understand that I'm having struggle, but I still don't want to follow that pattern. I want to do something else to just get my nervous system to do something different for myself. So
Interesting.
yeah, it's in the neurology literature. They talk about sensory tricks, and probably those are the ones. And I have known that a few children, actually they were noted to have some coughing behaviors. They would just cough and not do anything else, just because probably no one told them how to do abdominal breathing and get out of the episode by using pursed lip breathing, or like saying the sound and making it continuous.
Mm-hmm.
So anyway, they just cough, and they make sure the vocal folds are open, because after that violent cough, what happens? The vocal folds suddenly open, abduct to get in more air, because coughing induces some strong adduction or closing at the level of the vocal folds. So different children have different strategies, probably some self strategies. And then when they're given all this education and counseling and some right techniques to reduce this tension, and also like they receive some sort of education about their lifestyle or some exposure to some environmental factors, everything kind of works together to make sure the child understands the process of treatment and also the triggers and the BCD as a whole.
Yes.
So the concept is so important for them to realize, and this is what the speech pathologists do. And it doesn't take very many sessions to actually treat a child. So on an average, I would say probably 7 to 10 sessions if you're trying to work with a younger child and trying to establish the breathing pattern.
Mm-hmm.
But for adults, it's 1 or 2 or 3 sessions. They get all the information. They're good to go, and they're on their way, and always try to do their management, like self-management of symptoms. And for children, yeah, parents do monitor their symptoms, and from time to time remind them to actually
Oh, yeah.
get to those exercises. And I think there's some dosage that the literature suggests. If you are into those breathing exercises, probably it makes a big difference if you're able to do at least 3 sets during the day.
Mm-hmm.
So that helps a lot, just to make sure your respiratory system is tuned in to the needs or demands that you go through every day in life.
Well, you are a wealth of knowledge. I have a feeling that we have an expert here in this VCD area. I mean,
Oh my.
you are amazing with all of your knowledge in this area, and you've worked with a lot of people in this area too. So now, if someone out there has a question, are you open to them emailing you?
Yes, please. If someone has a question or someone has a client who they're trying to treat, and I would be more than happy to get connected, and they can call me or they can email me. So
Okay. Your email is jray at semo.edu. Is that correct?
yes, that's correct.
This has been amazingly interesting. Thank you so much, Jayanti.
Thank you again for this great opportunity. I truly enjoyed it.
Bye-bye.
Bye.
Thank you for listening to the Speech Link. Please check out my other offerings at my website, charvoshart.com, and also speechtherapypd.com. See you next time for more interviews, information, and insights. Until then, thank you so much for all that you do with your speech kids. Be well, and God bless.